Yeah, he's there.
Thank you, Mr. Chairperson, Dr. Neeraj Pandit. Uh, so a lot has been said about this theme by Dr. J.C. Mohan. However, I would confine myself to the short and ultra-short DAPT trials in the recent times. We know that DAPT is essential for preventing ischemic events after PCI, and it invariably leads to risk of bleeding. As much as 40% of subjects of routine PCI could be high bleeding risk patients, and the hemorrhagic consequences do add up to the overall net adverse events of these patients. And the recent trials on next generation DES have shown an acceptable safety profile with a short course of DAPT. However, the sweet spot about optimal DAPT duration remains elusive to us. There are no free lunches. We will discuss about it, citing a few trials that why long-term DAPTs are recommended, even in these guidelines, both European and American. The optimal DAPT duration depends on the clinical presentation at PCI, which is the acute coronary syndrome. The risk benefit depends on whether patient is high bleeding risk or not. So it's a trade-off between these two aspects of PCI. An ultra short DAPT, that is 1 month or 3 months, for which patients and which stents. That's another point of discussion. And the synergies between ultra short DAPT and P2Y12 inhibitor monotherapy would be the last part of the talk. There are no free lunches. This is a huge meta-analysis of Nevrezi of close to 32,000 patients. And it clearly says that if you give DAPT therapy in excess of 1 year, you are able to cancel out the adverse effect of bleeding and major bleeding or death by preventing a lot of ischemic complications. And therefore, in all comers, it is a default strategy even today, as per the guidelines, that one must give at least 1 year of DAPT, especially after acute coronary syndrome, and at least 6 months of DAPT after stable angina PCI. Now, the duration depends on the on the presentation. The SMART date randomized trial data, which came soon after the last 2017 guidelines on the acute coronary syndrome patient groups, including unstable angina, non-STEMI, and STEMI, and using the second generation stent in these patients. And it's clearly shown here that if you abbreviate the DAPT therapy to less than 6 months in ACS patients, it results into high MACE and high death rate. But if you prolong it, the bleeding complications are also high. The risk benefit depends on whether the patient is high bleeding risk or not. And this was alluded to by Dr. J.C. Mohan, that these are various criteria, including DAPT or precise DAPT, and so many of them. But largely what comes out is the patients who are elderly, who have CKD or liver problems, or have a past history of bleeding, are the ones who are susceptible to have bleeding. Therefore, these high bleeding risk patients have historically been excluded from majority of clinical trials. So here we look at some of the trials which specifically deal with the high bleeding risk patients. The Leaders Free trial was one trial where the Biolimus A9 stent was compared with the bare metal stent, and it was seen that the high bleeding risk patient, the safety and efficacy of this stent compared to bare metal stent was non-inferior when these patients received just about 1 month of DAPT followed by the monotherapy. Another important trial which was presented recently was Onyx 1, a stent which comes, the stable polymer stent which comes from Medtronic, that 1 month of DAPT given in patients of Onyx 1 followed by either aspirin or P2Y inhibitor for rest of the year did not result into any change in the adverse cardiac or coronary events. And there was no difference in the bleeding complications also if you prolong this therapy to at 1 year. And therefore, the data demonstrates that Resolute Onyx is safe and effective in complex high bleeding risk patients who receive just 1 month of DAPT. Now, the sweet spot, as I said, is elusive, whether it's 1 month or 3 months. So the trials on high bleeding risk patients are some of these which came out after the guidelines of 2017. The Leaders Free trial, which I showed, the evolved short depth trial, which was conducted last year in the elderly patients who received 3 months of DAPT and thereafter monotherapy. The global leaders trial, which was 1 month DAPT followed by 24 months of ticagrelor, was non-inferior. The TWILIGHT data, of course, I'll show it in subsequent slides, and the STOP DAPT2 data, which was conducted in all comers and 38% of acute coronary syndrome patients. And these patients were receiving 60% were receiving clopidogrel and 40% of prasugrel. And the ultra-short DAPT reduced the major and minor bleeding complications versus the standard DAPT in these all-comers, in which almost 38% patients had ACS. So the synergies between the ultra-short DAPT and the P2Y12 inhibitor monotherapy, which is the aspirin-free therapy. The global leader trial has clearly shown that aspirin is the biggest culprit when it comes to the high bleeding risk. And this was further reaffirmed by the GLASSY registry and the TWILIGHT, of course, which I'll show here. So in the STOP DEP2 data, the aspirin was given, the DAPT was given for 1 month, and following which the clopidogrel alone was continued for the rest of the time. And at the end of 5 years, what they found that there was no significant difference in the MACE or the ischemic complications of these patients. However, there was a clear-cut reduction in the TIMI major and minor bleeds and BARC 3 or 5 bleeding by abbreviating the DAPT therapy in this population. This trial has a caveat that there was a lack of consensus on the net adverse clinical event as a primary endpoint. In Japan, as such, the ischemic events are low and certain drugs were not available in Japan. So the conclusions of STOP DEPT 1 month or SMART choice 3 months would be that 1 month DAPT followed by clopidogrel monotherapy provided a net clinical benefit for ischemic and bleeding events over 12 months of DAPT. So we are inching forward towards more and more policy of shortening the DAPT duration of practice. The TWILIGHT data was presented last year in TCT by Dr. Roxana Mehran, and this data again shows that if you stop DAPT at 3 months and continue with ticagrelor monotherapy in a patient population which is high risk by virtue of both high bleeding risk and the angiographic high risk, as outlined here, there was clear improvement or benefit in terms of bleeding complications in the subgroup who was on monotherapy of ticagrelor. And there was no difference between the MACE, whether you give short-term DAPT or long-term DAPT. And that was very encouraging and could lead a path for the future guidelines that in a population of high-risk bleeding as well as ischemia, if you give short-term DAPT followed by ticagrelor monotherapy, it would reduce a lot of bleeding complications without impacting the ischemic events in these patients. And this was also replicated early this year in ACC in sub-studies of non-STEMI ACS patients, diabetic patients, and complex PCI patients, and the findings were. And then this trial came, the TICO trial, which was conducted on ticagrelor in dedicated acute coronary syndrome patients, unlike the TWILIGHT, which was in all-comers high-risk patients. And even in here, in ACS patients, when these patients were given 3 months of DAPT followed by 1 year of monotherapy with ticagrelor, would result into drastic improvement in the bleeding complications without impacting the thrombotic complications of these patients. And as you see in the top line, the significant parameters only the net adverse clinical events in the TIMI major bleeding, and the rest of the parameters were no different between the two subgroups. So there are few trials with aspirin monotherapy. Although aspirin is being given up more and more with the data, evolved short DAPT on the Synergy stand from Boston, which is a biodegradable polymer, was another trial where aspirin alone was continued after initial 1 month of DAPT. And then this data, which came just about in this TCT, Zines 90 and Zines 28, which is a global and all US trial, in which aspirin alone was continued after implanting the Zines stent in these patients with just 1 month of DAPT followed by monotherapy with aspirin. And these were the patients who were included. They were clearly high bleeding risk patients with the angiographic criteria, and the angiographic criteria with the target lesions were less than 32 millimeters length and less than 3 target lesions with less than 2 target lesions per vessels were treated. And in this population, The patients which were excluded were the STEMI patients or patients with poor LV function or patients planned for surgery within 1 to 3 months. And what they saw that by giving aspirin monotherapy after the initial period of DAPT would resulted into no difference in the ischemic events of patients, and this did result into significant reduction in the BARC 3 to 5 bleeding complications of these patients. So amongst high bleeding risk patients undergoing PCI with Zymes, a short DAPT regimen of 1 to 3 months compared with standard DAPT of 12 months resulted in non-inferior ischemic outcomes, similar rates of clinically relevant bleeding with significant reduction in major bleedings and very low incidence of stent thrombosis. So the guidelines as of now clearly say that for ACS patient, giving DAPT for 1 year is class 1A indication. However, in bare metal stents or low bleeding risk patients, it could be given for 1 year, but in a high bleeding risk patient, it could be stopped at even 6 months class 2B, C or class 2AB indication. On the other hand, in acute coronary syndrome, by rule, one must give DAPT class 1A indication for 1 year. However, in high bleeding risk patients, it could be stopped at 6 months class 2AB indication. Regarding the extended therapy, Dr. Simon alluded to in his talk by Pegasus and other data that in patients who have high ischemic risk but low bleeding risk, one can have the extended duration of DAPT in some of these patients. So to conclude, the shorter DAPT duration invariably involves a trade-off between higher ischemic and lower bleeding risk. Optimal duration of DAPT seems strongly dependent on whether the clinical presence PCI was acute coronary syndrome or not, and data on ultra-short DAPT duration after stenting in high bleeding risk patients seems encouraging. But trials comparing different DAPT durations in high bleeding risk patients are lacking. That is, 1 month may not be the sweet spot. The synergies between short and ultra-short DAPT plus P2Y monotherapy, true high potency monotherapy, that's ticagrelor, requires further investigation, and optimizing patient outcome ultimately depends on targeted, individualized approach to these PCI patients. Thank you for your kind attention.
Thank you, Dr. Chandra, for a very nice elucidation of the current evidence that's available. And also, as we can see that more and more, it also depends upon the design of the stent with the newer stents available and all, which is bioabsorbable or stable or no polymer at all, where the risk of thrombosis becomes less. And in high risk, there are so many good trials that you showed where the high bleeding risk patients can be managed by appropriate single like ticagrelor in TWILIGHT and various other studies. Thank you, Dr. Chandra.